why it matters, as well as some new technology that may help us in its treatment. My disclosures for this talk is I'm a paid consultant for Edwards Life Sciences. Really, just before we start looking at hypertension, this slide is really to remind me of the fundamentals of hemodynamics, and that is volume, flow, and pressure. We've come full circle in recent years. The early trials that looked at hemodynamic optimization, such as the Schumacher work, managed both pressure and flow. And then for a little while, we became focused on just goal-directed fluid therapy, managing volume and flow only, almost forgetting about pressure. We've now come back full circle with recent trials such as Fedora or Future incorporating pressure management after we've optimized volume and flow to improve patient outcomes further. And this is really highlighted in a recent meta-analysis in the European Journal of Anesthesiology. And essentially, the core message from this was that when you optimize flow and then improve blood pressure, you improve patient outcomes. Now, hypertension inherently, we know, is poor for patients. It's associated with poor patient outcomes, such as complications and perhaps even mortality. But at what threshold does the risk of harm increase? The first idea of what blood pressure threshold may be associated with harm is a study by Michael Walsh a number of years ago. 33,000 patients undergoing non-cardiac surgery. Very simply measured mean arterial pressure at various thresholds. As we can see here from the graph, with your mean arterial pressure of less than 55 millimeters of mercury, your risk of kidney and cardiac injury dramatically increases. A mean arterial pressure of less than 55 was associated with both these complications, and in terms of kidney injury, the risk escalated with the amount of time you spent below this threshold. For kidney injury, after 40 minutes, the risk is doubled. After 80, that risk was tripled. Now, there is some association with poor outcomes at slightly higher intraoperative mean arterial pressures between 55 and 59 millimeters of mercury for both kidney and cardiac injury, but nowhere near as strong. However, for most elective patients, they are probably not hypertensive for that level or for that duration of time, or at least no data exists to show that incidence. However, it doesn't really matter. There appears to be no safe duration for which the mean arterial pressure can be less than 55 millimeters of mercury. Even short periods of time associated with that level increase your risk of renal and cardiac injury. A cumulative time of hypertension at this threshold, so a duration of between 1 and 5 minutes, is associated with increased risk of kidney injury. And it's important to note it is the cumulative time. So not absolute episodes or single duration of episodes. It's the cumulative amount of hypertension that adds up over an operational procedure that leads to harm per se. Whilst the confidence intervals overlap, generally the longer you spend in hypertension, the higher the risk of the complications, both kidney and cardiac. And that's a very common theme and common message. The lower the blood pressure, the longer it's low for, the greater the amount of harm. A prolonged time below that limit in this study was associated with worse 30-day mortality, and that's at durations of greater than 20 minutes. The most recent study, and the largest to date, confirms the association between hypertension and myocardial and kidney injury. This time, 60,000 patients out of the Cleveland Clinic. What they showed, or the authors rather assessed the relationship between either relative decrease or absolute lowest mean arterial pressure, the time spent below these thresholds, and the outcomes in order to find the optimal BP threshold below which injury occurs. And what they showed was that a map of 65 or a decrease of 20% from your baseline, then the probability of kidney and cardiac injury increases. And as the map goes lower, so the incidence of outcomes increases. And so the optimal cutoffs they found was a map of below 65 or a 20% drop from your baseline value. And once again, to emphasize, this is the cumulative duration of hypertension at these levels. So they took these optimal thresholds, so 65 millimeters of mercury, and they looked at different quartiles of time spent below them. When we consider a map of less than 65, then once you spend 30 minutes or more below this threshold, the risk of myocardial and kidney injury increases. And the longer you spend below it, the higher the chance of injury. 1/3 of patients had a hypertensive load, so a map of less than 65 for more than 30 minutes in this study. And interestingly, 1/3 of the hypertension occurred between induction of anesthesia and knife to skin. That's anesthetic hypertension. Interesting paper, sets the bar much, much higher than previous papers, but in retrospect, the other papers hinted at that injury with slightly higher and prolonged exposures to maps of under 65. They were just too small to show a statistical difference. So hypertension is associated with harm. It's on our radar. The question is, does treating or avoiding hypertension make things better? And there is some evidence that avoiding hypertension is beneficial to patient outcomes. This is from the IMPRESS trial from Emmanuel Futier's group. So 2 groups, and in the intervention group, they kept the systolic blood pressure within 10% of the baseline measurements with a peripheral norepinephrine infusion during the operation and for 4 hours afterwards. And by managing blood pressure, by keeping it within 10% of baseline, they reduced post-op organ dysfunction from 51 to 38%. That's quite a significant relative risk reduction. However, it's important to note that this is not a trial of blood pressure management. This is a trial of goal-directed fluid therapy versus goal-directed hemodynamic therapy. When we looked at the appendix of this trial, both groups had fluid optimization. They had the stroke volume maximized, and then the intervention group also had the blood pressure optimized. So the standard treatment group had goal-directed fluid therapy. They had volume and flow managed. The intervention group, which showed the improved outcomes, had volume, flow, and pressure managed optimally. And by doing that, patient outcomes were improved. So hypertension is associated with poor patient outcomes. We know, or we've seen, that treating hypertension may actually improve those outcomes. But for hypertension to be a significant problem worthy of our attention, it actually needs to be prevalent. This is from 15,000 patients looking at different durations or definitions of hypertension. If we pick things we know are intuitively bad for patients, so here we have a mean arterial pressure of less than 40% of your baseline value. So almost half your baseline mean arterial pressure. Half of patients have this for a minute or so, and that's understandable. That might be a clamp coming off, it might be post-induction anesthesia. Probably can't avoid that. 4 out of 10 patients have this for 5 minutes or more. This is being a bit slow on the fluid or on the vasopressor. But 1 in 4 patients have a map that's almost half the baseline value for greater than 10 minutes. Now that is not viable, and that to me looks avoidable. This is untreated hypotension. Okay, so we can do better. We've seen that a map of less than 55, there is no time that a patient can have this without the risk of harm increasing. Yet a third of patients have this for a minute, and around about 5% of patients have this for 10 minutes or more. Less than 65 millimeters of mercury for more than 30 minutes, we see from the Cleveland data, is associated with kidney injury and with cardiac injury. And once again, not dissimilar to the paper by Salmassi, around about a third of patients have this level of hypertension for a duration that is associated with harm. And this accumulation of harm and the high incidence of hypertension has led to some guidance being produced for us. And this is from the POCI, or the Perioperative Quality Improvement Initiative, who've issued guidance saying that intraoperative mean arterial blood pressures between 60 and 70 millimeters of mercury are associated with patient harm. We're also seeing now merit-based incentive payments. So targeting reductions of hypertension using formal QI metrics. So there are payments now being made for when we avoid hypertension, assuming it's there to improve patient outcomes. But why is hypertension so prevalent? I mean, there are many reasons, there are various definitions, we don't measure it very well, but fundamentally, we can't treat what we don't measure. We still use oscillometric techniques, measuring blood pressure every 3 to 5 minutes. If we do that in the interim, there'll be incidents or periods of hypertension that we cannot see because you are not measuring it, and these will add up to harm or to levels that are associated with harm over time. One of the fundamental problems, though, is that we treat hypertension. We live in this state of reactive medicine. Something happens, that something is hypertension, and at some point after it's occurred, we treat it, we react. But in the interim, hypertension has happened for a very variable period of time. And once again, remember, it's the cumulative duration of hypertension that matters. Repeated small amounts over a procedure add up to levels that can lead to harm. But hypertension doesn't just occur. with the exception of a few surgical causes, there is a state of instability that precedes the actual event that we cannot detect with our standard monitoring. If we can detect or could detect this instability that would lead to hypertension, we could move to a state of proactive medicine, essentially treating the instability before the event, that is hypertension, actually occurs, and hence avoiding it. So the future now is perhaps predicting hypertension before it's even occurred. Under our algorithms that exist to take features from an arterial waveform that predict hypertension up to 15 minutes before it occurs. And this is called the Acumen Hypertension Prediction Index software, and it comes on the Acumen IQ sensor. Why the arterial waveform? Well, beyond the obvious, it measures the blood pressure. It gives us a huge amount of information about the cardiovascular system. Systolic rise time can tell us about contractility. Systolic decay time can tell us about large vessel compliance. The diastolic time looks at peripheral effects. So we can measure stroke volume, we can measure heart rate, a huge amount of information. And all in all, we can extract around about 160 different features from the arterial waveform. But in terms of how the algorithm is derived, it's not just based on these absolute waveform features. Why would it be? These are just static measurements at a single point in time. They don't predict hypertension. But how they interact does. So we look at variability. So variability of the parameters we can measure. So heart rate or cardiac output, it varies naturally. A heart rate of 60 isn't that. It isn't 60 constantly. It's 58 1 second, it's 60 the next, then it's 62. The average is 60. And as states of instability, such as hypertension, occur, this biological variability decreases in all our measured parameters. We can quantify this, we can measure it. The complexity of the arterial waveform system is also, arterial waveform signal rather, is also lost as we approach instability. Indeed, complexity of lots of variables change, heart rate, blood pressure, all sorts of variables. We can quantify this using a process called entropy, essentially a measure of complexity of the signal. And we can look at physiological links, the interaction between systemic vascular resistance or stroke volume or heart rate, how they react and change to each other. When we take all this information, we have around about 3,000 waveform features. So the 3,000 features for each individual waveform. And to start analyzing these, first of all, we look at those that predict hypertension with good strength. So they have a receiver operating curve, or AUC, of greater than 0.85. We take these best performing parameters, and then we derive what's called combinatorial permutations. So there are 51 factors that predict hypertension. We take these 51 and we multiply them together, 1, 2, or 3 features at a time at varying power, ranging from -2 to +2. And this helps us assess nonlinearity. What we end up with is 2.6 million features per arterial waveform. And that goes into machine learning algorithm applied to 150 million waveforms. And once it's gone through the machine learning process, mostly using sequential feature selection, it comes out with 23 of the most predictive features of hypertension. So 23 features that predict hypertension before it happens. And the full details of that are in the excellent paper by Hatib et al. In anesthesiology. What we end up with is an algorithm in a box, and you get a number as your output. This number is the hypertension prediction index. We also get some additional parameters, such as EA-dyne and DP-DT, and we'll talk about these a little bit later on. So what you get is not a mystery number from a box, but it's the output of a very complex algorithm derived from millions of features and vast amounts of data points that are used to predict the likelihood of hypertension occurring. So what is HPI? Well, HPI is a number. It goes from 1 to 100, and it relates to the likelihood of trending towards a hypertensive event. Now, the hypertensive event currently is defined as a mean arterial pressure of less than 65 millimeters of mercury for more than 1 minute. So the higher the number, the higher the likelihood of a hypertensive event, and the shorter the timescale to it happening. The lower the number, the less likely a hypertensive event will occur, and the longer the time to event if it does occur. To try and highlight this is data from one of the validation papers that we published at the start of this year. If we take, for example, a HPI between 20 and 29, about a third of those patients will become hypertensive in the future. And the average time to hypertension occurring is 8.7 minutes. Now, on the face of it, it looks quite bad. So a third of patients will be hypertensive, but as they approach hypertension, the output of HPI will become higher and higher and higher. With a HPI output of between 90 and 99, almost all patients, so 86.4% of patients, will become hypertensive, and the average time to hypertension is 2.3 minutes. So the higher the number, the more likely hypertension is to occur, and the shorter the timescale to it occurring. The lower the number, the less likely hypertension is to occur, and the longer the time to event. But why is this important? Well, by predicting hypertension, the whole premise is that you can intervene. This is from an anterior resection done a number of months ago. The black line is HPI, and the red line is our mean arterial pressure. So we cross the value of 85 for HPI. This is the point at which it alarms because it has a high positive predictive value beyond this point. And we don't see hypertension occurring until 7 minutes later. And the whole premise of this technology is that in the interim, you can intervene. So we're warned of hypertension is about to occur or is going to occur. We can look at the underlying physiology, decide what we need to treat, and treat it before the hypertension actually occurs, avoiding these repeated dips into hypertension that we know add up to harm over time. But does it work? Well, in terms of predicting hypertension, this is data from 250 patients undergoing major non-cardiac surgery, and around about 250,000 data points were collected. It's a bootstrap analysis with over 2,000 iterations. In terms of predicting hypertension, predicting at 5 minutes in advance, the area under the curve is around about 0.926, decreasing to 0.879, predicting it 15 minutes before it happens. As you get further away from events, all algorithms get less predictive. Okay, it's hard to predict things further and further away than it is closer to time, but still very good AUCs out at 15 minutes. So we have an algorithm that will predict hypertension before it occurs, up to 15 minutes, but it has to have incremental value. It has to be better than the things we currently measure. So if we look at mean arterial pressure, first of all, this is comparing HPI and looking at changes on mean arterial pressure over a 3-minute change this time in terms of predicting hypertension. Changes in MAPS, so changes in mean arterial pressure, do not predict impending hypertension. It doesn't matter whether you take delta maps of 3 minutes, 20 seconds, 5 minutes, it's a coin toss. The area under the curves are all about the same, around about 0.5 or slightly higher. But we measure other things in theatre or in the perioperative period. And if we compare HPI to the more advanced parameters, such as cardiac output, stroke volume, pulse pressure, shock index, or stroke volume variation, it still outperforms them all. And that makes sense. HPI is a multi-parametric output or algorithm taking 23 different features, some of which are combinations of different physiological variables. So it makes sense. It is more predictive than just measuring or looking at single variables. What HPI is doing is taking all this complex information that we collect, and it's giving us the output that we can understand in terms of a numerical value. But it may be something more than just being a warning or alert of impending hypertension. What HPI doing is quantifying the process that leads to hypertension, that is cardiovascular instability. So HPI might be telling us or measuring or quantifying increasing amounts of hypertension, of cardiac instability that ultimately will lead to hypertension. So delta HPI may be just as important. A change in HPI means there's more instability being put into the system, and that should alert us more or alert us to that underlying instability. It's really important, though, to remember we don't treat the number, we don't treat HPI per se, we treat the underlying cause, and we have to do that by looking at the physiology. I'm just going to focus on 2 new parameters, the first one being dynamic arterial elastance, or EA-DYNE. Let's take an example of a patient we see every day. We have a patient that's hypertensive. We know they're in a preload dependent state for looking at our preload dependent parameters, so SPV or PPV. And therefore, when we give them fluid, we know that will increase stroke volume, but that has an unknown effect on blood pressure. because whether that increase in stroke volume translates to an increase in mean arterial pressure depends on a parameter called elastance. So elastance is the reciprocal of compliance. So it's pressure divided by volume. It's the tendency of a vessel to want to recoil to its original dimensions. Effective arterial elastance has been proposed as a measure of our left ventricular afterload, and it's defined as a slope of a theoretical line through the end diastolic and end systolic points of the pressure volume loop of the left ventricle. So essentially, effective arterial elastance is our end systolic pressure divided by our stroke volume. Why is that a useful physiological parameter? Well, when the aorta opens, or as your valve opens rather, the left ventricle wants to expel its stroke volume into the aorta, and it's confronted with this afterload or aortic input impedance. The left ventricle mainly sees just the proximal part of the aorta, and it has three main characteristics. So it's filled with blood that needs to be moved, so inertia has to be overcome. It's already pressurized at our end diastolic pressure, so that has to be overcome, and it has an elastic wall, compliance or elastance, that counteracts the further filling. So when that aortic valve opens, the ventricular elastance becomes coupled to the arterial elastance. And it's good to know whether that afterload is relatively stiff, that's a high elastance, or relatively compliant, it has a low elastance. Because in the first case, increasing stroke volume will create extra pressure, both pulse and mean, and in the second case, extra stroke volume will be mostly absorbed by the low elastic state. So if it's highly elastic, increasing stroke volume will create pressure and vice versa. Now, we can't measure effective arterial elastance in our operating rooms or in intensive care particularly easily. So the concept of dynamic arterial elastance has been suggested as a functional measure of arterial load. And it's the ratio of our pulse pressure variation to our stroke volume variation. And it's called dynamic arterial elastance. It is not a measure of arterial load per se. It just defines the dynamic interaction of changes in pulse pressure and stroke volume over time. And remember, pressure over volume is essentially elastance. And it measures it over a respiratory cycle. So it's not the same as arterial elastance. It's not the same as systemic vascular resistance. A high EA-dyne does not mean a high SVR or vice versa. A very similar analogy is that the preload responsive parameters, stroke volume variation, and pulse pressure variation are not direct measures of preload. They just tell you whether the patient is preload responsive or not. So EA-dyne, what it allows us to do is determine whether a preload responsive individual, then if we increase stroke volume, will that lead to an increase in pressure? This is pressure volume relationship for a given vessel. And here at the lower end, we see a situation where there is low elastance. So the lower end of the curve. If we look at a volume change, and that's all the stroke volume variation is, if that volume change does not lead to a pressure change, so pulse pressure variation, then our EA-dyne is low. So pulse pressure variation divided by stroke volume variation, 10 over 15.67. If this individual, if we give fluid, we will increase their stroke volume because they are preload responsive, but that increase in stroke volume will not translate to an increase in pressure, which have a low elastic state. So when the EA-dyne is low, we know that giving fluid in preload responsive individuals will not improve their blood pressure. Conversely, on the highly elastic parts of this pressure volume curve, that same volume change leads to a significant pressure change. So this time our EA-dyne is high. PPV over SPV, 25 over 15, 1.67. In this case, giving volume to this patient will increase their stroke volume because they're preload responsive, and that stroke volume translates into an increase in blood pressure because of the highly elastic part of the curve. So EA-dyne is telling us in preload responsive individuals whether giving fluid will increase their blood pressure or not. So EA-dyne really is the interaction of large vessel elastance and our ventricular contractility. It suggests whether a patient who is fluid responsive, so preload dependent, will also increase the arterial pressure to fluid administration. Optimal cutoff, predicting mean arterial pressure rises around about 1, but a grey zone of 0.8 to 1.2 doesn't exist. And there is also evidence that we can use EADI to help us safely titrate vasopressor therapy. And we'll look at that in the lab a bit later on. The second parameter we can use to treat hypertension is one that looks at its contractility. So looking at dp/dt, a measure of the systolic slope of a peripheral arterial waveform. So physiologically, true contractility is the slope of an end systolic pressure-volume relationship. So if we take or look at a PV loop and we change the preload, decreasing it, and we join the end systolic points up, this is our end systolic pressure-volume relationship, and the gradient of that line is our end systolic elastance. That's a true measure of myocardial contractility. The steeper it is, the more contractile the heart is. The shallower it is, the less contractile the heart is. But once again, we cannot measure this in theatre, so we're seeking alternative or surrogate measures of contractility. And one that has come to attention or interest is the maximal change in pressure over slope measured from a peripheral arterial waveform as a surrogate for our left ventricular contractility. It's a large assumption that our end systolic elastance, so true LV contractility, is equal to left ventricular dp/dt, which then equals this peripheral measurement of dp/dt. And of course, they're not the same thing. What they do is they correlate or change together in the same direction. So we can use it as a trending parameter. So changes in peripherally measured dp/dt reflect changes in true left ventricular contractility. This was shown in one study by De Hurst. Now, in this time, it was measured femoral pressure time changes. The HPI uses a radial measurement. This one, however, used femoral. But what they saw was changes in true ventricular contractility were reflected and it correlated with changes in this femoral measurement of contractility. But importantly, it reflected changes in left ventricular contractility during various interventions. So during passive leg raising, during calcium administration, during dobutamine infusions. So this gives it great clinical utility. So it tracks true measure of RV contractility, and it tracks it when we do or perform interventions. There are limitations to arterial dp/dt. It's only been studied in limited populations. It always underestimates true contractility, but they do trend in the same direction, and there are no normal values for arterial dp/dt. That's why I use it as a trending parameter and not as the absolute value. It can be affected by other factors apart from contractility per se, and it has to be used in caution with patients with severe aortic stenosis, invasive diplegia, and in grossly underfilled states. So really just to round it up before the virtual physiology lab, hypertension is harmful in terms of kidney and cardiac complications, and probably more as well. And hypertension is very prevalent. The lower the blood pressure, the longer it's low for, the higher the risk of harm. And HPI is a machine learning algorithm that predicts hypertension or the likelihood of a patient trending towards a hypertensive event up to 15 minutes before it occurs. Additional parameters such as EADI and dp/dt will help us assist in making informed treatment choices when treating hypertension.
Thank you so much, Simon. Now in the next section, we welcome you to the Edwards Virtual Physiology Lab experience. In the past, the only way to explore real-time physiological responses was to do so in actual practice or within a controlled laboratory setting. This really limited the experience to in-person programs for only a very small group of clinicians, which required a significant time commitment. We are excited to bring to you the Virtual Physiology Lab, a program which allows us to utilize these past programs to demonstrate key learnings and the experiences of hemodynamic responses as they relate to a variety of common physiological changes that are known to occur during the perioperative continuum. Today, we will be focusing primarily on the utility of Acumen HPI software in the management of hemodynamics, including the role of volume, flow, and pressure. Monty and Simon will be our lab proctors for today. Here is a quick overview of the lab environment. This is a porcine model. It is an approximately 75 kilogram landrace Yorkshire mixed pig. Now, these animals were selected carefully as their physiology behaves remarkably similar to humans. In this particular model here, the animal is under general anesthesia and is intubated and ventilated with positive pressure ventilation. A variety of monitoring was performed, including arterial line, Swan-Ganz catheter, Acumen IQ sensor. In addition, we also have intracardiac echocardiogram images, and along with that, some images of the microcirculation of the GI tract, which really be like a special treat for everyone today. Estimated total blood volume of the animal is approximately 5 liters, and we will be looking at primarily a controlled hemorrhage model. So with that, I will hand it over to Monty and Simon for the first segment of the virtual physiology lab today, which focuses on the hemorrhage model. So this will be a slow and continuous hemorrhage, and it will approximate for a 20% blood loss over a period of time.
Grand. So, Monty, should we just orientate ourselves to what we see on the screen first of all? So, on our left-hand side there, we have our basic bedside monitor. So, common parameters, our heart rate, our invasive arterial blood pressure in the red there, and we also have our pulmonary artery pressures in the yellow, CVP, and our saturations. Bottom left there on the scales, that will measure the amount of hemorrhage we're seeing. As Monty said, it's a 5 litre model, so every 50 mils is round about a 1% hemorrhage. So 100 mils, 10% hemorrhage or thereabouts. On the right-hand side, the big screen, we have our advanced monitoring, so from our hemisphere with our Acumen HPI software. So our top trend there is our hypotension prediction index. Below that, we have our mean arterial pressure, our stroke volume, and our stroke volume variation. Remember, that's a measure of our preload responsiveness. Bottom figures there, self-explanatory cardiac output. We have our measure of contractility, dP/dt. Our measure of being pressure responsive, which is EA-dyne, and of course, our systemic vascular resistance. So let's get into the hemorrhage as the bleeding starts now, and we can start to see the scales there increasing. Now, just to let you know, this is at times 2 speed in order so we can get through this in a timely manner. Right, so baseline values all looking pretty unremarkable, Monty.
Yeah, so Simon, there was an immediate little uptick there of HPI. I'm assuming that was just a coincidence because, I mean, it had been almost no hemorrhage at all.
Yeah, hard to say, Monty, but actually you frequently see once you start taking even just a small amount of volume from the models, that subtle physiological change is detected by the algorithm. And then as you compensate for that, because it's relatively small amounts of hemorrhage, we see that come back down to our baseline value again.
And just to remind ourselves, with HPI, it's not a physiological variable, it's a predictive index, and low means hypotension unlikely to happen. As it rises, it means hypotension more likely to happen.
Absolutely. It's not a physiological number. It's a combination of 23 different variables, some of which incorporate physiological parameters, but in itself, it is the output from an algorithm. And as you said, the higher it is, the more likely you are to be hypotensive moving forward.
Right, so there's a lot happening with our high-end monitor at the moment. I think some line flushing going on and stuff, but we're getting, remind us again, so we've just got over the 125 grams or mils of blood. So remind us what percentage that is again?
So that's between 2 and 3% of our blood volume. So 50 mils is 1% hemorrhage. And what we're up to there, so 150 mils, we're about at 3% now. And we're starting to see some changes in our HPI output now. So it's gone from our baseline around about 20 up to 41 now. No real other changes, anything else from measuring, heart rates, constants, blood pressure pretty much unchanged. And if anything, our stroke volume is a little bit higher than it was. SVV on the cusp of being fluid responsive up at 14 there, but no real significant change from when we started.
But we do have to remind ourselves that even though at the moment it's only 150 mil or so blood loss, that still has to be compensated for because the intravascular volume is relatively low, and of the intravascular volume, the so-called stressed volume is even lower. So to maintain central hemodynamics and stroke volume and everything else looking good, the body still has to compensate, doesn't it?
Absolutely. We are designed to protect ourselves, to protect oxygen delivery to our mitochondria, to our cells, and most of our critical organs. So even small amounts of hemorrhage, when we compensate, it has to come from somewhere. So there's nothing for free. we have to frequently rob Peter to pay Paul.
And typically we're told that, we know we can donate a unit of blood. So that's, and not everyone tolerates that well, but most people who are recurrent donors tolerate it very well. In order to be able to stand up after blood donation, you'll have to have compromised some blood supply somewhere to maintain central blood volume. That's autonomically controlled. So that's probably why HPI has shot up now. It's probably telling us things that are happening in the way you described earlier that the human eye can't detect, because I must admit there's nothing that I can see on the high-end monitor that would tell me that there's 250 mils of blood in the bucket.
No, absolutely nothing at all. So we're up to about 5% hemorrhage there. And as you say, Monty, absolutely. We're moving fluid or volume from our unstressed circulation into our stressed circulation, and that comes with autonomic changes. And that's one of the things that HPI is measuring, that change or that autonomic dysfunction that we start to see. And you can see that as we've started to hemorrhage, there's a slow but steady increase in our HPI. So as we're causing more and more instability in the model, we're getting a higher and higher output from our HPI. And if we look around, I can't really see any significant changes from anything else. Stroke volume, etc., is pretty reasonable. Map hasn't changed. The only thing we're seeing really is a slight increase in our stroke volume variation, and that makes sense because we're losing volume.
Exactly, and I think that's becoming, I think that many people would react to that SVV in isolation. They might give a fluid challenge to see if it comes down. The other things we should note is, as we know, that heart rate is not a reliable indicator of hemorrhage unless it's combined with trauma and fear and anxiety, which is why you do see it in trauma. But in silent hemorrhage like this, heart rate is not a sentinel indicator of hemorrhage. MAP's staying pretty steady, as are the PA pressures, and in particular the CVP, because it is that compensation by squeezing the unstressed volume into stressed volume that keeps the central volume status rock steady. This is physiology in action.
So just remember this picture here, and we'll go back to it a bit later on, Monty, and we've got some microcirculation pictures at around about 300 mils of hemorrhage coming up. And so macroscopically, so our macrohemodynamics at this point all look pretty normal and unchanged from baseline.
Yeah, I've been involved in some human hemorrhage experiments in the past, including hemorrhaging humans and looking at the microcirculation with a surrogate measure. And this is about where you'd be expecting that microcirc to go down as part of your compensatory mechanism.
And that we can't see because on the outside, everything's looking pretty good still, isn't it? SVV's a bit up, but otherwise good blood pressure, good flow, stroke volumes up at 100 mils plus. I think if you wandered in and you didn't see blood on the floor, you'd be thinking, maybe a bit of fluid based on SVV, but otherwise looking pretty good.
Yeah, it's coming up now on what percentage now? Coming up towards the sort of 9-10%.
Once we get to 500, we'll be about 10% hemorrhage there. So 500 mils of blood on the floor. And actually, that's relatively easy to achieve. A bit on the surgeon's boots, some swabs, 100 mils in the sucker, a bit on the drapes. You can have a relatively covert hemorrhage of 500 mils without really noticing. And certainly looking at those monitors, I can't see anything really changing. The trends all look pretty flat, except HPI that's still trending in an upwards trajectory.
Yeah, and some people say, what's your problem? Stop stressing about it because the other numbers look fine. Your cardiac output's okay. You can imagine your DO2's okay. But as you say, you have to rob Peter to pay Paul here. So there's some parts of your body that now aren't seeing a blood supply. And that's Absolutely. Okay for a while, but it's not a long-term survival strategy. And we'll come back to that.
And the question we have to ask ourselves is, where's that blood coming from? We have some, I'm not going to say spare blood, it isn't spare because everything has a consequence, but from our venous capacitance vessels, from our spleen, and from our gut circulation, that's what gets sacrificed first of all, and we'll see that a bit later on. So whilst on the surface, everything's looking pretty good, with the exception of HPI, underneath that, as we'll see, there are physiological changes that, if left long-term, may cause patients some outcomes.
So the idea of the stressed and unstressed volume, which we keep going on about, the stressed is in the stretchy vessels. That's where your pulse happens. It's in your great veins, etc. Now, there's a little bit of unstressed volume that you can give up for free, typically squeeze it out of your spleen, for example. But almost all of the rest of it is in the microcirculation, because remember, the microcirculation is constant flow. There's no generation of pulsed pressure. So it is unstressed, but it's all doing a job in there. It's all looking after your organs.
Absolutely, and we'll see a bit later on that the effects that losing or mobilizing that unstressed volume has in terms of our gut microcirculation. And we can tolerate changes in this transiently for half an hour or so, but if we have long-term reductions in our gut circulation, then there are consequences that we will look at.
Absolutely. Now, the HPI's, Simon, is just hitting the red line there. What does that mean?
So the red line is 85, Monty, and that is the threshold that historically we've used to start initiating treatment because the positive predictive value at that point is very high. Once you get over 85, almost all patients will become hypertensive in the near future.
Okay, so looking around for a moment, heart rate unchanged. I think the map's dropped a little bit there. I'm not sure I'd be jumping up and down about it in isolation, but it's gone down by a few points.
Absolutely. And the interesting thing, Monty, look at the delta map compared to the delta HPI on that trend screen there. That's a marked difference.
And as you would expect, because we're now starting to decompensate a little bit, we're starting to get an increase in SVV as our HPI is screaming at us. CVP is possibly down a notch, which means you're starting to lose the compensatory battle now.
Yeah, so I think on our advanced monitor, we've got some clear signs that something's happening. Raised SVV, HPI is up over 90 now. On our standard bedside monitor, though, not a huge amount of change. Some subtle changes, as you say, but nothing particularly dramatic.
Do you think you can eyeball the so-called swing in the arterial line? I don't know, my eyesight's failing at this stage, but
with the eye of faith, knowing what the SVV is, yeah, you could say that. But it's not crystal clear. It's not a bond or swing on that line, I don't think.
Now, the CVP and the PA pressures will drop eventually. You could argue they're dropping a tad now. The PAD maybe is down a notch or two. They will go down, but they're very, very late indicators, aren't they?
Very much so. And we can see that from the bottom left-hand screen there. We've got over 600 mils of blood in that bag. I'm only just seeing changes in PA pressures and CVP now. So very, very late indicators indeed. And that 500 mil hemorrhage has to be compensated for by something. And as you were saying, Monty, that's mobilizing that unstressed volume into our stress circulation.
And now the map is dropping on the right-hand monitor to a level whereby we should probably be doing something about it in isolation, but we've got a lot of blood in the bucket now as we begin to become hypotensive, and the SVV is taking a proper kick up now.
Yeah, and only now we're starting to see our stroke volume start to decrease, and that's physiological. We compensate until the very last, until we can compensate no more. So dropping stroke volume and changes in CVP, PA pressures, very, very late indicators of significant hemorrhage.
So if you wait for this to act, and this is very representative, as I said, I have been involved in a number of human hemorrhage experiments and many animal experiments. If you wait till now, then you're way off the mark.
Absolutely. If you're treating a CVP or a PA pressure or waiting for the pressure to drop, those are when you're becoming decompensated. So very, very late changes, and you've had significant physiological change up until that point. And if we look at the advanced monitoring, if we look at the trending, I think we can clearly see what the early indicator of hemorrhage and physiological instability is. It's this HPI algorithm that does all the things that we can't do. It takes lots of different variables, some of the data that we see amongst us or before us now, and it combines those into a single output that we can understand. So a very, very complex algorithm taking vast amounts of data.
Now, people are often a little bit surprised. They say, "Hang on, your model is wrong here because the heart rate is not increasing." And as we said earlier, there's a strong belief that heart rate tells you something about hemorrhage. So please, if you have any doubt about this, go and reread the controlled human hemorrhage data, the classical papers, that the last indicator of life-threatening hypovolemia is bradycardia. The tachycardia happens if you have trauma, stress, anxiety, surgical stimulation. and it's not a primary indicator of hypovolemia.
So in your human models, Monty, when you were hemorrhaging your colleagues and friends, you saw no change in heart rate at all throughout that?
No, and very reproducible. I said the only thing that's happened is the sixth volunteer in our original study developed a bradycardia and lost consciousness. It's all in the paper, extremely well described. That is, and remind ourselves again, it's painless. This is painless atraumatic hemorrhage. It's different if you break a leg or get stabbed or shot. There's a lot of other things going on. But if you're having a silent hemorrhage, it's bradycardia that happens.
And we're approaching almost, 900 mils now, so not shy of 20% hemorrhage. And it's only now, our CVP is still around about 8, our PA pressures haven't changed dramatically. As you mentioned before, Monty, heart rate is unchanged. Actually, that's a significant hemorrhage. If we did have the advanced monitoring, and you walked into a room, you may not pick that up, apart from there's a large pool of blood on the floor.
Yeah, actually you did walk in now, Simon, and MAP's 58. What would you do? I know we'd all give volume. We get that bit. That's easy. But would you give a little bit of pressor to temporize the situation?
I would. A little bit of sort of rescue vasopressor, just to salvage the situation while you get that volume in. A vasopressor, it's not a bad thing. It treats something. It temporizes a situation while you figure out what the underlying cause is, and then treat it appropriately. So, while I'm trying to get volume in, I think I'd let the blood pressure a little bit higher. I'd use a vasopressor for that.
Because you want to maintain a heart-lung-brain circulation, because heart attacks and strokes are very, very bad. But at this stage, apart from the fact we've compromised a lot of end-organ perfusion, our kidneys are probably suffering severely at this stage as well.
Yep, we've had a couple of minutes of blood pressure under 65 now, and certainly trending towards 55 now as well. So no doubt there's some organ dysfunction or organ injury starting to occur. So our HPIs trended upwards. It passed 85. It gave us about 3 or 4 minutes notice of hypotension occurring. We didn't see our blood pressure drop below 65 until about 4 minutes after HPI went above that 85 threshold. So it gave us plenty of notice to look at that physiology. Because remember, we don't treat HPI. That's just a number. We treat the underlying physiology that is causing us to trend towards hypotension, which in this case was clearly hypovolemia, because we can see the blood in the bag.
Classical physiology.
Wonderful stuff, isn't it? Absolutely wonderful.
So your EA dying DPDT, not a lot happening there, which I think I understand now that's what you'd expect, Simon, isn't it? Because you're maintaining a reasonable degree of filling of the heart with the stroke volume, etc. Afterload has adjusted, so SVR's dropped in order to try and maintain an organ perfusion. Yeah,
so again, one of the things that we're commonly told is that as we hemorrhage, SVR goes up to maintain our blood pressure, but actually that's not physiological. SVR often decreases to maintain that forward flow, so we perfuse our organs. Contractility hasn't really changed. We're mobilizing our unstressed volume into our stress circulation to maintain our left ventricular end diastolic volume and therefore our contractility. And our EA dyne is raised because we know now that this model is preload responsive, and if we give some preload, so give some fluid or blood back, we will increase the blood pressure because EA dyne is raised.
Well, it looks like we've finished this period of hemorrhage.
Super.
Very, very educational. Thank you.
Excellent physiology in action. So, Monty, we were talking before about robbing Peter to pay Paul, moving stress circulation or unstressed volume into our stress circulation. And I think one of the things you were touching on is the effect it has on the microcirculation, because that has a large storage or proportion of our unstressed volume. So it might be quite nice to look at that. This is where we started. So these are our baseline values. And could you just take us through what the gut microcirculation looks like?
Do we have some images of that? Yes, we do. Thank you very much indeed for that. This is, I recognize these. On the left-hand side, as you look at it, is an electron micrograph of a sample of porcine or pig microvillus in the small bowel that I took few decades ago with some friends in London for a series of experiments. So it's a beautiful EM. You can see the microvillus structure there. And on the right-hand side, you see it as a cartoon. So these beautiful finger-like structures that you can only really see properly with an electron micrograph. You can't see them clearly with a light microscopy. You can see on the right-hand side that the finger-like structure there with the cells, the single layer of cells, has a centrilobular arteriole wrapped around by a venule going to the base of the microvillus, which is in the mucosa. You see below that the submucosa and the muscularis, which is the muscular bit. The thing to note, because you have this countercurrent blood flow system, is that there is a degradation of oxygen levels from the base to the tip. So as you go from 100 millimeters of mercury in the arteriole at the base with full flow and in health, by the time you get to the tip, it's down to 40. You also have a buildup of CO2 from the base to the tip. That means at the tip, you're getting programmed cell death or apoptosis on a regular basis. Now, a small reduction in blood flow will immediately result in the oxygen jumping from the arteriole to the venule, and the microvillus is exquisitely sensitive to underperfusion or persistent periods of poor blood supply. And that's what we might go on to see, I'm guessing.
Yeah, so we've got some pictures that you and I took in the lab, and this is at baseline. So that's a well-resuscitated model, so no signs of hyperperfusion, and this is the pictures of the gut microcirculation. So those thumb-like structures are the villi that you were just talking about, Monty, with that central arterial vessel going right up the middle, and then flow coming down the sides there through the venules. And flow in the microcirculation, Monty, is constant, isn't it?
It is in health. We may see later on that as it becomes compromised, it can become pulsatile, which is unhealthy in the microcirculation, and or it can transiently reverse itself or stagnate completely. But microcirculatory flow in health is constant.
Grand. And so in this picture here, that was a healthy microcirculation, blood flow in all the villi. And so that's our baseline to remember. So 300 mil blood loss in the model we've just been through. Now, from my memory and looking at that screen there, no real changes in any of our parameters, blood pressure, stroke volume, SVV, all pretty much the same as baseline. But we have lost 300 mils, and that has to come from somewhere. So should we have a look at the microvilli again?
And HPIs are up a lot, which I think is the indicator of the compensation.
Very much so.
Beautiful pictures there. Left-hand side as we look at it healthy.
Yep, and the right-hand side, I mean, we've got straight away quite a blanched villus in the centre there with not much flow. And we've got a change in the way the blood is flowing. In our baseline value or baseline picture, that flow was constant and non-pulsatile. And now what we're seeing is intermittent pulsatile flow in those villi, and that is abnormal. Now, it's heterogeneous. There are little bits that look okay. There are bits that are blanched. There are bits that have intermittent flow. That's a very, very different picture to our baseline values. You know, that microcirculation is starting to suffer a little, Monty, would you say?
Yeah, absolutely. But I mean, this is what we do to be able to stress ourselves, to exert ourselves every day of the week. If we go above our anaerobic threshold, this happens. If we donate a unit of blood, this happens. And it's okay if it's transient. Depending on the individual response, you can tolerate this for a couple of hours, but some people are sensitive, and by hour 3, it's starting to necrose the tips of their microvilli, and certainly out by about 4 hours, almost everyone's in a bit of trouble, and that manifests itself post-operatively as post-operative nausea and vomiting, and if it's severe, it manifests itself as a GI tract dysfunction or an ileus or ileus.
So the worrying thing for me, Monty, is the normality that we see on our major monitors. So our heart rate, our blood pressure, our stroke volume, all unchanged. And so if we're not exquisitely careful with our fluid, making sure our patients are euvolemic, not using vasopressors to mask that hypovolemia, then we could have this for a good couple of hours during surgery and not know, because we can't see this. With the exception, perhaps, that HPI was a little raised, suggesting there was some underlying instability there.
Yeah, when I did some of the earlier studies in adults undergoing major surgery, it might be up to about 50% to patients who have some degree of hypovolemia and inappropriate use of vasopressors who get these types of changes, not measured with SDF cameras, but alternative technologies, who went on to have worse outcomes in all the ways that you might anticipate. I mean, many people get away with it. They just have a little bit of sickness afterwards, a little bit of nausea, a little bit of throwing up. But in some people, it goes all the way through to multiple organ failure in a small percentage.
Grand. Shall we look at what 10% hemorrhage looks like then, a little bit further on?
Absolutely.
And I think if we look at our macro hemodynamics again, I think from memory at 500 mils, there wasn't a huge amount of change once again. Heart rate's unchanged, as you mentioned before, Monty. We've still got a decent mean arterial pressure, so over 70 or 70 milliliters of mercury. Stroke volume's all great. Our SPV is still a little bit on the high side, so we know they're fluid responsive. I mean, the screaming thing there is HPI, it's trended right up. It's in the red, it's flashing, it's alerting. The rest of it, apart from SPV, all looks pretty reasonable. Let's have a look at what our gut looks like at this stage then.
Yeah.
So, not as good
Anyone
as before.
can spot that, eh?
Yeah, pretty much. Blanched, pulsatile, areas of just no flow whatsoever. I mean, that's suffering a bit now.
Absolutely. Again, good to remind ourselves about the biology of why and how this makes you feel sick post-operatively, is that your GI tract is teeming. It's got a large stores of serotonin, of 5-HT3. And when the drugs like ondansetron were originally discovered, they radio-labeled the 5-HT3 in the microvillus of the gut. They poisoned the gut with drugs such as cisplatin, and they watched it track up through the vagus into the vomiting center to cause sickness. So that's how they developed the modern antiemetics, to both antagonize the receptors in the GI tract and in the vomiting center in the brain. So that's PON-V in action that you're looking at there.
Because of that countercurrent mechanism, Monty, because of that low flow state, you're getting a lot of oxygen exchange at the base of that villus. So the tip is almost anoxic now. You did have some great pictures, some electron microscopes of villi that have been hypoxic for a little while. You just talk us through those.
Well, you immediately get some accelerated apoptosis and programmed cell death. But then if you get to this stage, you're going to get some necrosis, which again is all completely survival. We do it to ourselves on a not infrequent basis if you do some more extreme sports. But when that happens, you're inevitably going to get some degree of GI tract dysfunction. So, and if there's any marathon runners or ultra athletes listening, a percentage of you will get so-called runner's trots. You'll have, uncontrollable problems with your GI tract after major events. What you're looking at here is what's happening inside you.
So one of the concerns we have, I think we both share, Monty, with the focus on blood pressure now, avoiding hypertension, which is a positive thing. But one of the things that may happen is that people start vasopressors at the start of surgery, and they gradually just creep up to maintain blood pressure, perhaps at the expense of ignoring the volume status. And this is quite an extreme example that we show here. This is a 1,000 mil hemorrhage, so a litre of blood loss that you and I normalized with a vasopressor. So we've lost a litre of blood, we've started a vasopressor, we've titrated it so that our hemodynamics look normal. That is very, very simple to do. Good blood pressure, good stroke volume, SPVs below 14, good cardiac output. But if we go to our microcirculation, I think this is the... look at that.
That's what to be very, very scared of. You can give vasopressors safely if you're euvolemic, and ideally under GA, just a tad hypervolemic. But any hint of hypovolemia, and the GI tract pays a real price. You can see that's very, very unhealthy there.
If you're not careful, you can mask that hypovolemia. You can get a completely normal macrohemodynamics. You're under the bonnet. This is what's happening. I mean, that's just no flow in most of those villi, complete stagnation. And the only thing we see moving there is actually externalized blood or slurry in the bowel. There's zero flow in that villus there. And that's very well masked. Our monitors all look normal. So a real word of caution there. So I hope what we've seen during this model of hemorrhage is that we see changes in the HPI. HPI before we see changes in any other parameter that we measure. HPI is a very, very early indicator of hemodynamic instability that suggests may lead then to hypertension. And as you know, stroke volume and cardiac output are preserved despite significant blood loss. As Monty alluded to before, we mobilize our unstressed circulation into our stress circulation to maintain stroke volume until we can do it no more. Central euvolemia is maintained, but our total circulation or circulating volume is depleted. And hypertension only occurs when the system can just no longer compensate. And once again, as Monty showed, heart rate unchanged. It is not an indicator of hemorrhage in any way, shape, or form outside of trauma.
All right, that's great. So thanks a lot, Monty and Simon. I think that overview was excellent. Especially looking into the videos of the gut microcirculation. I think that's really amazing footage that I have. So with this, let's go into the Q&A session right now. And I see that there are many questions that have already come up. So maybe Monty and Simon, if you want to come up on the stage again, with your videos and cameras on, and maybe one by one, we can go through some of the questions that have come in. Okay. So yeah, going through the questions in the chronological order. Now, the first question is from MRK. I'm not sure the full form, but the question is, can the threshold that is mapped less than 65 be changed in HPI platform, depending upon the patient condition? Example like ischemic cerebrovascular disease patients with uncontrolled hypertension requiring surgery, wherein anesthetist prefers to keep MAP around 70 or more. That's the first question.
So currently, the definition of MAP is fixed at a mean arterial pressure of less than 65 for greater than 1 minute. There are iterations of the technology that we've seen working that have user-defined thresholds, and that is going to FDA for approval at some point in the future. So we will see personalized thresholds moving forward, but the current definition is fixed at 65. I mean, that said, Sanjog, the reason that was chosen, that if we, as a group of anaesthetists, just improved our game to keep blood pressure over 65, that would be an improvement of what we're doing currently. But absolutely agree with whoever said that question. For some people, we'll want a more individualized target that might be slightly higher, and predictive ability to predict that will come in the future, but currently not available.
Thanks, Simon, for the comment. And again, further, to this is what we have seen now since HPI has been, in the Asia region for approximately like 2 years. And, we see some clinicians now, since they have had some experience in patients, now they're looking at the HPI number a little bit earlier, than 85. So, do you think that's probably, an approach till we, have the second iteration available?
Well, see, we've been in the lab doing some stuff on looking at HPI recently, haven't we, in different numbers?
And I think supported by the lab data, but also anecdotally, it looks like a number of about 50 is where it starts to become interesting, put it that way. And that's actually supported by the earlier HPI data. I just think that the approval of the device at 85 was taking a very conservative approach to an alarm threshold.
Thanks, Monty. Okay, this next question is from Dr. Subramani Kandaswamy. Is peripheral perfusion index being monitored in this model? And if so, what is the change when HPI is like in the 50s?
We did do you mean perfusion index taken from a pulse oximeter? I can't remember what we looked at. I don't remember noting that during the hemorrhage. It was a very highly instrumented animal. We've certainly had measures of peripheral perfusion in terms of lactate measurements, which throughout the hemorrhage were completely unchanged. But no, in terms of PI measurements, no, we didn't take note of those.
Noted, Simon. Another question from Dr. Nayan Lai. It's a comment plus a question. HPI seems to work very well in predictive hypotension from hypovolemia. Does it still perform in distributive shock, cardiogenic shock, and obstructive shock? And the second part of the question is, would pneumoperitoneum during laparoscopic surgeries change the utility of HPI?
So we take the first part of the question. Monty have both done controlled or induced cardiogenic shock with esmolol infusions at very low doses, so gradually creeping up. And HPI, again, informs you of that underlying instability before you see changes in any other parameter. So it doesn't really matter what the cause of the instability is, and that cause of instability, going on to the second part, could also be pneumoperitoneum. Then HPI will detect those physiological changes that occur from either cardiogenic shock, giving a low dose esmolol, or inducing external events such as pneumoperitoneum. So yes, it works across all of those different areas and gives you the earliest warning that you'll see compared to the common things that we measure.
And Simon, if I'm right, when we look at the validation, the original validation paper for the development of the algorithm, it was clear that the developmental cohort, the human cohort, and the validation cohort included both elective surgical and critically ill patients. So we're reasonably confident the whole spectrum is covered.
Very much so. It's not a disease-specific algorithm, is it, Monty? It's looking at physiological changes that occur regardless of the state or disease states that you're measuring.
Great. Thanks, Simon and Monty. The next question is from Dr. Vijay Kumar. I think the question was around cardiogenic shock, which probably going to be covered in this question. Next question is from Dr. Thepakon. Was this experiment conducted in animals or humans? Probably it's referring, to the hemorrhage model that we were seeing. And the next part of the question is, if it was done in animals, can all parameters generalize to humans as well, since the AI algorithm was derived from humans?
So the reason we chose that particular model is I've been involved in bleeding humans in the past, and the physiological changes are identical. Now, we haven't done controlled human hemorrhage experiments with HPI yet, but there's no reason to believe it would be any different. That's actually a bit of work that's in progress at the moment. It seems a bit of unnecessarily verification, but that's we can't help ourselves. But as I say, the changes that we see in humans are identical to the changes we saw in the animal. And although the algorithm was developed in humans, it predicts in the animal. So we think we're looking at the same physiology.
Thanks, Monty. The question from Dr. Nayanla, is HPA validated in obstetric patients? It's more specific to, as Simon, you said, it's not for any specific procedure as such, but can it be applicable in obstetrics as well?
There is one specific paper out there that looked at HPI. I think it was from the non-invasive cuff version, which correlates very well and has very similar receiver-operator curves. That was validated in an obstetric population undergoing cesarean section and had the same predictability and very similar rock curves to the original validation study. So yes, it does.
Great. Right. Next question again from Dr. Nayan Lai is, can we use sublingual microcirculatory changes as a surrogate marker of changes in the microvilli?
Yes.
I think that's a straight answer, Dr. Nayan. Dr. Sahadol from Thailand, in the future, can we customize threshold of MAP other than 65? So I think, Simon, you alluded to this answer in the first question itself. So,
yep. So awaiting FDA approval, but it's technically is possible and currently exists.
Right. Okay. Next question from Dr. Subramani. Do we need a PA catheter data to calculate HPI? What other data other than given by multi-parameter monitor in ORs or ICU is necessary to calculate? So yeah, I'll just take that one. So Dr. Subramani, it needs an arterial catheter, an existing arterial catheter, which is the Acumen HPI. You don't need a PA catheter, at this moment at all to calculate HPI. But Simon, Monty, open to you and any comments.
But I mean, the quality of the arterial waveform that you derive is a key variable.
Yeah. The other thing to point out, Sanjog, is we can now get HPI from non-invasive cuff measurements as well. So whilst we can do it from arterial monitoring, the Acumen cuff will generate a peripheral continuous waveform from a finger, and from that we can derive HPI and some other parameters that we'll look at in the next part of the lab.
But it doesn't require any other input variable, no CVP, no heart rate, no pulmonary artery catheter. They were just used in the experiment to make comparative measures.
Right. Thanks, Monty and Simon. And this is for everyone's information, is we don't have the Acumen cuff yet with us, which is, the predictive cuff monitoring in Asia, but, that will soon be available, going at the end of the year and next year onwards. So, yeah, that will be available, non-invasive as well in the near future. Then we have MRK's Dr. Radhakrishnan from NIMHANS, and he has another question. Is now hemosphere comes with inbuilt cerebral oximetry. Would that be included in the HPI calculation? And sometimes we see stable RSO2 in spite of MAP coming below 65. So should this value still be treated?
So I suppose two things. First of all, no, HPI is purely generated from an arterial waveform, so has no other external inputs at all. In terms of cerebral saturations, it's a good question, but because your brain is perfused, it doesn't mean that your kidneys and your heart and your gut are well perfused. Certainly once you've gone below your lower limit of autoregulation in terms of your cerebral perfusion, your other organs are probably suffering. The variation in the autoregulation thresholds from organ to organ means that if you've got normal cerebral saturations, it doesn't mean that the rest of the guts are also well perfused. So it's a combination of information we take. We're not fixed on one value, but if the MAP was below 65 and I had normal cerebral saturations, I would still treat hypertension because I think the kidneys and the gut are also suffering. But treat it in the correct way is the key.
Thanks, Simon, for the answer. We just have 2 more minutes for this, and we'll definitely keep some of the questions at the end, because we'll again come back at the Q&A as well. So let's take maybe a couple more. So what is the correlation? This is from Dr. Chidananda. What's the correlation between HPI and serial lactate measurements?
Well, we did those in the experiments, didn't we, Simon? We did serial lactate measurements, and we published it in our first ANA paper, and not a lot really is the answer. Which is the same as when we bled, but when we bled humans as well. The Hamilton-Davis paper from the last century, when we bled humans up to 25% of their blood volume, there's no lactate change. You do get the lactate change once you reperfuse, but for the same reasons that you're cutting the blood supply off to different areas, like shock resuscitation, you don't get the lactate signal until there's been a long time delay, because it has to leak out through the tissues, because it's being generated in non-perfused tissues. So no major lactate clue in the acute phase.
Just to emphasise that, but the models that Monty did in terms of hemorrhage had been progressively hypotensive for 2 to 3 hours with various vasopressor loads, and had normal lactates until we reinfused and restored circulating volume.
Thanks both for the comments. Maybe one last question before we go into the break, and then the pending questions we'll definitely ensure to cover in the next session. At what value? This is Dr. PJ Casey from KMC. At what value of HPI should we intervene? Should we wait till 85, or should we look into it earlier now?
Right. So the alarm goes at 85. You have to tread carefully here. My inclination is that I would intervene, this is a personal opinion, at around 50. Simon?
Simon, any comments?
I would concur with Monty. I think there's 2 things, the absolute threshold and the delta change of HPI. If it's gone from 10 to 20 to 30 pretty quickly, I would prick my ears up and have my eyes open and look around. There's increased instability. And when we get to around about the 50, 60 mark, I would start to treat if there was an obvious physiological derangement underlying that.
I mean, the latest lab study that we've completed, Simon did the majority of the work with one of his students, which is the paper's in preparation at the moment. It's around that level where you see the loss of microcirculatory perfusion, isn't it, Simon?
It is, and also that's from a volume point of view. But coincidentally, when we were doing the negative inotrope experiments as well, It was around about 50. Shortly after that, you started to see derangements in stroke volume and contractility. But at 50 was the early warning sign prior to any macro disturbance.
And I think from the point of treatment, the first thing it prompts is to have a good look around what might be causing it. And then I think there's sort of general consensus from people who've had a lot of experience now that if you're just not sure, try a little fluid bolus. And if it goes down, then there was probably a volume deficit, obviously within the bounds of what you regard as a safe positive fluid balance.
Awesome. So I think that's a lot of great discussion, and we still have a lot of pending questions. We still have another section of the physiology lab to go. So with that, we will go into a quick break for the next 5 minutes only, and we'll come back after the meeting. See you all soon. Welcome back, everyone. Now I would like to again invite Monty and Simon to come up on the stage for the next section of the physiology lab. In this section, we will be walking through fluid responsiveness and how to reutilize EA time. Also, during this situation, we will be giving some fluid challenges while we are looking at this parameter in particular. But before we do that, we are going to have Simon provide us a little bit more details on the clinical utility of EA time.
So EADine, dynamic arterial elastance. So EADine, what is it? It's our pulse pressure variation divided by our stroke volume variation. So it's pressure divided by volume, and that is a measure of elastance. Why is that a useful parameter for us? Well, remember this pressure volume curve from before. If we look at the grey boxes on the left-hand side, we have a preload responsive patient, so the stroke volume variation is raised, it's 15%. But that change in stroke volume over a respiratory cycle isn't causing a change in pulse pressure or blood pressure. So the ratio of the two, SVV over PPV, is low, it's 0.67. So in that individual, giving fluid is the right thing to do. They are preload responsive, so it will increase the stroke volume, but that increase in stroke volume will not translate into an increase in blood pressure. So when your EADine is low, giving fluid, you'll improve your blood pressure, improve your stroke volume, but you won't improve your blood pressure. On the right-hand side in the red is a patient who's on the highly elastic part of a pressure volume curve. So the same volume change over respiration, SVV is raised, but this time it causes a change in pulse pressure variation. EADine is high, so 25 over 15, 1.67. So when an EADine is high, if you're preload responsive, when you give fluid, you increase stroke volume, and that increase in stroke volume generates blood pressure. So EADine is telling us that in preload responsive individuals, will giving fluid increase blood pressure or not? And there's been lots of use. I think we looked at this a bit earlier on. This is from Ignacio's group from Spain, looking at all sorts of predictors of increasing your blood pressure to a fluid bolus, looking at SVR, looking at effective arterial elastance, and essentially EADine is probably the better predictor by far of increasing blood pressure to a fluid bolus if you're a preload responsive individual. And the cutoff they came in up with was 0.089. And there's also interestingly been some work looking at EADine as a tool to decrease or to manage vasopressor infusions on the intensive care units. Mostly comes from one group. But what that group found was that when your EADine was less than 0.94, then when you dropped or decreased vasopressor, your MAP dropped. Whereas it was above 0.94 and you decreased your vasopressor by a preset amount, blood pressure was maintained. And that group then went on to use this in a protocolized fashion to manage vasopressor infusions on the intensive care unit. And they reduced vasopressor infusion duration and also length of stay in ICU by over a day. So different clinical utilities. But really the key thing, the thing we really have to remember, EADine is not the same as systemic vascular resistance. We do not chase EADine with inotropes or vasopressors to achieve a preset value. It's a number that relates to how our ventricle and our large vessel compliances or elastances interact. So really important, it's not the same as SVR. Don't chase EADine with norepinephrine infusions. So this is our model once again. And at this point, our baseline values here, we can see heart rate 82, blood pressure a little bit on the low side, so 68, a bit of a swing on the art line there, replicated by a raised SVV on our advanced monitor. We can see already HPI is high, it's been over 85, and we have started a fluid challenge at this point. Now, EADine is raised, it's 1.3. And just to really refresh, in terms of being able to use EADine as a measure of being pressure responsive, the patient has to be preload responsive, which they are in this case. The SVV is raised, it's at 19. They also have to be hypotensive or trending towards hypotension. There's no point giving somebody, or somebody will not increase their blood pressure if their map is, say, 100, okay? Our baroreceptors, our feedback mechanisms won't allow that to happen. There has to be hypotension or trending towards hypotension.
So let me see if I got this right. So I'm relatively new to EA dyne. I mean, worked with you in the lab doing these experiments now, but just to be clear, everything's screaming at me that they probably need some volume, but you're telling me that because the EA dyne is greater than 1.2, for example, that when I give the volume, which is the right thing to do, I will get a pressure response. So you're telling me my blood pressure will go up with the fluid. Is that right?
Absolutely. So in this situation, we all know they need fluid. It's screaming high. SPV is really high. We know there's been a hemorrhage. So we know giving fluid is the right thing to do. We know giving fluid will improve our stroke volume because our stroke volume variation is raised. What EA dyne tells us is, will that also fix the hypertension problem? So it's letting us know what to do, whether that intervention we're giving is going to fix our flow and our pressure or just fix our flow.
So now HPI is coming down with your volume, SVV is coming down with your volume, and MAP's starting to go up with your volume?
Yeah, MAP's being maintained, starting to trend upwards. And by HPI coming down, I think to me, what it's telling us is we're doing the right thing. We're performing an intervention, and by giving that intervention, we're taking some instability out of the system, and that's reflected in HPI starting to decrease.
So what if the EA dyne was 0.8? Because they still need volume, don't they?
Absolutely. It tells us just as much information. It's telling us then that, well, we need fluid, our SPV is raised, we're hemorrhaging, but that fluid's not going to fix our blood pressure problem. So at that point, you're thinking, well, I'll give the fluid because we need to improve flow. We're also going to need something else to improve blood pressure or maintain blood pressure.
Okay, so heart rate's okay, everything else is looking all right. If the EA dyne was 0.8, I'd open up my roller clamp and let the fluid run in while giving a little squeeze of phenylephrine, just a little hit of something.
No, I think so. We've got a patient that's preload response to Monty. We're giving that fluid, absolutely the right thing to do, but it's not going to fix blood pressure if EA dyne is low. And so then we've got two things to think of. Is it contractility or is it some vasoplegia? And our DPDT, that measure of contractility, hasn't changed. And therefore, by default, we know it must be a problem with some vascular tone. So yeah, absolutely, fluid and a little bit of phenylephrine.
But in this example here, fluid on its own is doing the trick.
Yep, we're starting to see our baseline blood pressure was, I think, 69 millimeters of mercury, and we're now up to 75, 77 there. So giving the fluid has improved or maintained our blood pressure. Although interestingly, HPI is still raised.
Yeah, would you keep going, or do you turn around and say, well, hang on a second, how much fluid have I given so far? There are some sort of swim lanes. As to, if we were doing the case together and we were discussing this, I'd say, well, how positive do you think you are now? Because I wouldn't want you to go sort of more than 2 litres positive, chasing that HPI fluid.
There's no absolutes on the Monty. It's all about the context. If you were in the early phases and you were 250 mils positive, I think you think, well, let's try a bit more fluid.
Okay.
That seems a reasonable thing to do. If you're hitting on 2 litres, we know from the relief trial that once you're over 2 litres, you start to see some worse outcome for patients then. So you think long and hard about whether fluid is the right thing to do at that point.
So it's always volume, flow, pressure, the trilogy we're trying to fix, but you have to put the brakes on somewhere if you think you're getting too positive. Okay, thanks for that.
Once you say, Monty, 2 litre mark, you think long and hard about, fluid may still be the right thing to do, but a good long, hard think about it.
Yeah.
So we've given some fluid, Monty. We can see our stroke volume trending up there, our SVB coming down. So we were preload responsive. We've given fluid. SVB's come down. Our stroke volume is increasing. We've seen our blood pressure go from 69 systolic mean arterial pressure up to 79, 80 now. Our HPI has come down from the 85, 90s down to 60 or so. So we've avoided hypotension. When HPI was over 85, had we not treated that, hypotension would have happened in the next 2 or 3 minutes. By looking at the underlying physiology, by deciding what the cause was and the right thing to do, by knowing that giving fluid improved our stroke volume from SVV, and by knowing that stroke volume would improve our blood pressure by looking at EA dyne, be given the appropriate intervention to avoid hypotension.
Very good. Very good.
So in terms of EA-dyne, EA-dyne is a parameter. Remember, EA-dyne is PPV over SVV, and it tells us whether a fluid bolus will increase a patient's blood pressure if they are preload responsive. As with the other dynamic parameters, when interpreting EA-dyne, certain conditions have to be met. So the patient does need to be preload responsive, and the patient has to be hypotensive or trending towards hypotension. The optimal cutoff for EA-dyne is round about 1. So over 1, you're pretty certain that if you're a preload responder, if you give fluid, your blood pressure will go up. But as with all things in life, there is a grey zone. It's around about 0.8 to 1.2. And as we've reiterated time and time again, EA-dyne is not the same as systemic vascular resistance. It's not a number we chase with vasopressors.
And some with grey zones, that doesn't mean don't do nothing, does it? It means just proceed with caution.
Absolutely. It means think, Monty.
Yeah. Okay. Thank you.
Thank you, Simon and Monty. All right. So addressed in the next section of the lab, we will be talking about systolic slope or DPDT and how that behaves when we are in a variety of changes with contractility. So we will be giving a couple of medications to alter the physiology to have different contractility and see the response. But again, before we move ahead into the model, Simon's going to walk us through some of the key points of DPDT.
So yeah, just a quick refresh on what DPDT is. So change in pressure divided by change in time measured from a peripheral arterial waveform, so usually on radial artery. And it's something we all see every day, as mentioned in our first lecture. We know that patients with a good, strong heart have a nice, strong upslope on the arterial line. They generate a high pressure, and they generate it quickly. So DPDT is high. That's a good contracting ventricle. Patient with a failing heart, sluggish upslope on the arterial line, doesn't generate as much pressure, takes longer time to generate that pressure. So DPDT is lower. So high value, good contractility, low value, poor contractility. However, when we use it clinically, what we're using it for is as a measure or as a trending parameter. We don't use it as an absolute value. There are no age normalized values for DPDT. So end-systolic elastance is an accepted measure of left ventricular contractility, probably the pure physiological measure, and changes in this peripheral DPDT correlate with left ventricular contractility. And we can use this to guide us in treating hypotension and deciding what the underlying cause of impending hypotension is. And once again, it's a parameter we use from change of baseline and trend values rather than absolute numbers. So in this section of the virtual physiology lab, we're looking at contractility via DPDT. And firstly, we're looking at the effects of an esmolol bolus on contractility. So esmolol is a beta blocker and should have some negative, or rather does have some negative inotropy and chronotropic properties. Just to reorientate ourselves, the screen setup is very similar to our last part of the virtual physiology lab, except our bottom trend has changed from SVV to DPDT. That is change in pressure over change in time, which is a measurement or a surrogate for our left ventricular contractility. Now, if we run the model here, what we'll see is the model's being delivered a bolus of esmolol, and we should see some of the negative inotropic effects. And Monty, just remind me, esmolol's quite a short-acting drug.
Yeah, it's short, well, fast on, fast offset, so it affects some pretty immediate effects and highly selective beta-1 activity. So you should get the marked, negative inotropic effects you're anticipating, and I presume, therefore, quite a drop in DPDT.
Absolutely. So DPDT is truly a surrogate for our left ventricular contractility. With this bolus of esmolol, we should see this number start to decrease. Remember, a high number represents good contractility. A decreasing or low number represents worsening or poor contractility. So the bolus has been given, HPI starts to raise, and I think as we talked about before, Monty, HPI cannot predict this kind of external influence or intervention, but it will react to it. And what we should eventually is our contractility, so DP, DT, start to decrease, HPI will increase, and our stroke volume should start to drop.
So is it not just part of the effect a change in heart rate as well, Simon, is with the beta blocker? Is that what you'd anticipate too, or?
So we should see a change in our heart rate. It should start to decrease, some negative chronotropic effect, and that actually, Monty, might cause our stroke volume to increase slightly at first as we get improved left ventricular end diastolic volume. I think we saw a little blip up there in stroke volume, but now we start to see that true effect of esmolol. Stroke volume starts to decrease, and more importantly, that decrease in contractility is being reflected by a decrease in our DP-DT.
So this you're saying is less to emphasize the HPI effect because we gave the beta blocker here. It's a very artificial scenario, but pretty clear reduction in DP-DT there. So
absolutely, this is not looking at the predictive effects of HPI because it can't predict an external intervention such as this. Really focusing on, does DP-DT represent what's going on in terms of our left ventricular contractility? And as we've given that negative inotrope, we're seeing our DP-DT start to decrease and our stroke volume also start to decrease as well.
So if you're looking at this and trying to make a decision about a therapeutic intervention, as you have had a drop in DPD and hypotension and everything else that goes with it, primary intervention would be to try and improve your DPDT by giving an inotrope of something.
Very much so. So when we go through our pathways to try and determine which the correct intervention is, one of the things we'll look at is our contractility. Just a note there, well, SVV has increased quite dramatically or significantly, and that's because we've induced right heart failure as well with our esmolol bolus. And in that situation with right heart failure, we can't use SVV. So slightly artificial elevation there, but just to point that out to people viewing this today.
It's a very nice example.
Good. So yeah, DPDT has decreased from our starting values of around about 230 or so down to 160. So a substantial relative reduction in contractility, and we've seen our stroke volume decrease by a very similar amount as well. So DPDT seems to reflect, certainly in terms of the pharmacological intervention, a measurement of our left ventricular contractility.
And the proof of the pudding.
Indeed. So, Monty, you're more cardiac than I, so just talk us through what this is.
I'm a recovering cardiothoracic anaesthetist, but this is a short axis view. This was taken with the cardiac echo, so a very nice short axis view of the left ventricle, just around the level of the mitral chordae there. A typical sort of so-called donut view. So for those of you who are very experienced at this, you'll be able to spot it straight away as being good ventricular function. Those less familiar, the thing to remind yourself of is to sort of focus on the middle of the donut and watch everything thicken and come towards that central point.
So that's a pretty normal looking echo to you then, Monty?
Yeah.
Grand, excellent. So let's look at the one following the esmolol bolus and following our DP-DT decreasing.
Yeah,
and a pretty striking change, I'd say there.
You can spot that one on day one of your echo training. That's an unhappy LV.
Absolutely. Fractional error change is minimal. We see the decrease or the decreased chronotropic effect, and very little change in volumes there through systole, so a very low ejection fraction and stroke volume. So it seems to reinforce, if we put things side by side, that drop in DPDT is reflected by echo cardiological changes when we view the heart as well.
Great, very neat.
Super. So we've looked at negative inotropy, so let's have a look at positive inotropy and see whether DPDT reflects changes there. So if we run the simulation now, or the model now rather, we'll start some dobutamine, so a positive inotrope, and from giving dobutamine we should expect some increase in inotropy. So DPDT should go up from the baseline that we see there of 195, and would also expect an increase in our heart rate as well. So baseline heart rate there, 71. So that should increase with dobutamine infusion as well.
Can you just clarify, Sam, is this dobutamine straight on top of the esmolol, or is the esmolol washed out at this stage and you're adding the dobutamine?
We've had a little washout period there, Monty, so we're starting again from baseline.
So getting in there, so it's going to be pretty brisk.
Yep.
So it's happening already. Yep.
So there's our DPDT going up. Our heart rates increased from 70 up to 80. Our straight volume is dropping a bit there at the start. But there's good physiological reasons why that may happen.
Yeah, same as the other way around. You've reduced the filling time, so you're less of a chance to generate a left ventricular end diastolic volume. So the tachycardia will make up for it from the point of view of what happens with cardiac output, and you'll get your map up. But you're balancing those off. But as a rescue measure, it's going to seem to be an appropriate thing to do.
Absolutely. So the tachycardia is causing a reduction in our ventricular volumes, and so our straight volume drops initially, but that'll be compensated for shortly by the inotropy. So DPDT now increasing, gone from 190 up to over 300 now, so a substantial increase, 30% rise in that measure of contractility. Our blood pressure is also starting to increase now, so we're getting that positive inotropic effect, increasing our stroke volume shortly, hopefully, and doing all the things it should do.
So you'd expect the stroke volume to settle down after you have the initial effect as you just start to rebalance things. Are you going to be able to an echo in a moment to show us this as well, Simon, to see those processes?
I think we have the same intracardiac echo, Monty, okay. So we can have a look at that shortly and show that positive inotropic effect. So the end of this here, we've seen our contractility go from 190 in terms of DPDT up to 360 there, so quite a large rise. And if we look at our echo,
absolutely. There we go.
So again, left-hand side is our baseline, which we talked through. Right-hand side now, we can see that end diastolic volume is significantly reduced. A larger straight volume, so large ejection fraction, and that whole heart just looks a bit more hyperdynamic now, so improved inotropy.
No, everyone thinking, if this patient had some critical ischemia, for example, this may not be helping them at the moment because we're making the heart work hard, it's going quickly, we've reduced the filling time, but in this situation where that's not what we think we're up against, and it's a rescue measure to treat hypotension, then it's the correct intervention. Well, then, adjust that once we settle things down, but we need to rapidly get our mean arterial pressure above a critical level, we believe.
Absolutely, and we're using the information, we're using different parameters just to try and rationalise our treatments and choose the correct treatments for that particular cause of hypotension.
Right, again, quite an artificial situation, but very educational.
Absolutely, really there just to highlight the use of DPDT and the fact that it does change or track changes rather in inotropy. So DPDT is a measure of our left ventricular contractility, which we derive from the systolic slope of the arterial waveform. And I think, as we touched on before, Monty, it's a parameter we use as a trend and not an absolute value. So a dropping or decreasing DPDT suggests contractility is starting to worsen, and increasing value suggests contractility is improving. And we use this to help determine and treat the underlying cause of hypotension or impending hypotension.
Thank you again, Simon and Monty. Now, in this final session of Edwards Physiology Lab, we are going to explore changes in afterload and the use of vasopressors. Again, Monty and Simon, if we can really help come up, we can go ahead and get it set up.
So in this final part of our virtual physiology lab, we're looking at the effects of vasopressors. And I think we touched on vasopressors and their potential dangers in the first part of the lab, but they do have appropriate use at the appropriate time. And we can look at our simulation here to look at the effects of a vasopressor in terms of HPI and our other hemodynamic parameters. Now, Monty, this is a phenylephrine bolus or infusion that we're giving, is that correct?
It is. It's a straightforward piece of alpha agonism. So therefore, predominantly SVR, we believe we're affecting by giving this particular drug at the moment. The systemic vascular resistance.
So when we started, our HPI was high, suggesting that we were trending towards hypertension. Our SBV was low. It's below or at 11%, so we don't need fluid. So we've covered that base. This is a well-filled model. Our contractility is reasonable for this physiology. And so we can see our SVR is quite low. And we've given a alpha agonist, and we should see an increase in that and a remedy or rectifying of our hypertension.
And we discussed this earlier on. It's giving, under this situation, alpha agonism, irrespective of volume status, is we believe to be the correct rescue intervention. Whether it turns out to be the correct longer-term intervention brings us back to those discussions we had before about volume status. If we think we're adequately filled, which we think we are here, then giving alpha agonist to increase afterload and get pressure up to give us a reasonable map is where we are currently with our hemodynamic management.
Absolutely. So when we gave the vasopressor, we were not volume responsive. We'd filled up the model beforehand, and we've given this alpha agonist, and we've seen an increase in our SVR and also in our mean arterial pressure. Interestingly, Monty, EA dyne hasn't changed.
Yeah, and you wouldn't expect it to under this circumstance. You just said you're not preload responsive. EA dyne is the dynamic elastin, so is a component of afterload, the stretch of the vessel component of it. But here under this scenario, you would expect just an SVR and map change predominantly. Now, Simon, if this was right towards the beginning of the case, this is a discussion about whether you can still have a degree of mild hypovolemia at the beginning of the case with intermittent positive pressure ventilation in the chest. If I wanted to also give my 10 mils per kilo around the time of induction of anesthesia, even though the patient's not preload responsive as judged by SBV, would you allow me to do that, or would you criticise me for giving fluid unnecessarily?
I think it's very hard to criticise that, Monty. I think we know from what we saw in our first part of the physiology lab that SVV is a slightly late change towards hypovolemia at the microcirculatory level. And we know that by positive pressure ventilating individuals, we make them relatively fluid deplete. So perfectly reasonable thing to do, and actually physiologically very sensible.
Yeah, but about that 10 mils per kilo, so maybe up to that litre of fluid around the time of induction and anaesthesia is the current thought process is that's the right thing to do, backed up by some recent large studies.
Absolutely. So, up to a litre positive, I don't think many people would have any concerns over that, and many would actually see that as a positive, and rightly so. I think once we get over the 2 litre mark, as we touched on before, that's when we start thinking long and hard about whether that's the right thing to do or not. And it may well be, we just need to stop and pause.
So that was a transient effect there we saw, but will make sense.
So transient effects from a bolus of vasopressor, and despite warning of the potential dangers of inappropriate vasopressor usage, particularly in the hypovolemic state, vasopressors are the correct treatment for vasoplegia. Now, vasopressor administration can worsen the organ perfusion in the face of a hypovolemic patient, but it's a good salvage measure or rescue measure for hypertension in the interim. But the underlying message that I think we've preached throughout this, Monty, volume, flow, and pressure, fixed in that order, still predominates. And again, the key message, EA dyne is not the same as SVR. I think we've seen that in the last section. It's not a number we chase with the vasopressor.
Thanks a lot, Simon and Monty, for all the great insights. So with that, would you like to quickly help summarize the whole virtual physiology lab sessions?
Well, I think what we've shown is that HPI, this complex algorithm, is a very early indicator of hemodynamic instability and really starts to change before we see any other changes in the commonly measured parameters that we look at in theatre. I really just re-emphasise HPI predicts the likelihood of trending towards a hypertensive event. And as part of that software suite, what we have are some additional parameters that perhaps help us rationalize our treatment of hypertension. We have DPDT, this rise of the systolic slope, which is a surrogate for our left ventricular contractility. And we have the parameter that we discussed quite a lot today, EA-dyne, which helps us determine whether fluid will improve blood pressure in preload dependent patients. And I think what we're trying to do is take this warning sign of impending hypertension from HPI to make us look at the physiology, look at the situation around us, and then use these additional parameters to help determine what is that underlying cause of instability, what's going to cause hypertension, and how do I treat that in the correct manner.
Oh, that's great. Thank you so much, Simon and Monty. I think all those lab recordings, especially and seeing them with the echo were just excellent. So with that, let us go into the Q&A. And a quick note for everyone, all the attendees here. If you want to type in your questions, I think we already have, some questions in the chat box. But for those of you who are trying to, type in more questions, there is a chat box available, and you can feel free to type in your your questions in the chat box. Another option is, in case if you want to, ask your questions verbally, or have any comments, please raise your hands, and we can also try to see, if we can have some of you come up online. We have about 7 more minutes, and with that, let's jump into the Q&As. So, Monty and Simon, I would request you both to come up on the screen again, and let's go. So I'll just take up some questions that were, pending from the previous Q&A. There is one question from Dr. Chidananda about its applicability of HPI in the ICU setting. So, Monty or Simon, any experience that we have with HPI in the ICU?
So, as we discussed earlier, the development of HPI included the development using intensive care critically ill adult patients and was subsequently validated in that. And we hear reports of people using it, particularly in the resuscitation phase, where it makes very good sense that it would be as useful as anywhere else in determining, the correct treatment of preload, afterload, and contractility. But myself and Simon over the weekend were also discussing an area that we're hearing more about, which is using the secondary screen to help the appropriate weaning of inotropes. Simon, do you want to touch on that?
Yeah, gaining quite a lot of popularity, certainly in Europe and the US. So using EA-dyne to rationalize your vasopressor use and decrease your vasopressor load. And these tend to be quite simplistic protocols, nurse-led at the bedside. And there is some good emerging evidence that reduces the amount of time that you spend on the intensive care unit, mostly because you get that vasopressor off a bit quicker.
Thanks, both. Next question is from Dr. Subramani. Is there a difference in HPI derived from a radial versus a femoral artery in shock state?
It's a very good question. I think the simple answer is we don't know for sure. HPI is only validated from a radial waveform. That said, in clinical practice in ICU and in our experiments in the lab, we've used femoral arterial signals, and anecdotally we've seen no difference in HPI net output. But technically, it's not been validated in femoral arteries.
Work in progress.
Next question from Dr. Arpit from Sydney. Ventricular arterial coupling is a new physiological variable to me. How has the hemosphere helped you understand this?
I don't think anyone understands it truly, Sanjog. So ventricular arterial coupling, it's a good question. So your balance of your end-systolic elastance and your effective arterial elastance, which represents the ability or the interaction between mechanical and oxygen efficiency of the heart. Interestingly, EA-dyne seems to be a measure of ventricular arterial coupling. The higher EA-dyne, the closer you are to a VAC of 1. And what that means is that when you're well balanced, you're generating the right amount of stroke volume to generate the right amount of pressure at the lowest myocardial oxygen expenditure. And that means if you're heading around about the 1 mark, you can increase your mechanical efficiency of the heart to increase stroke volume, blood pressure, etc. So there is information there. I think that concept is quite complex. I don't think many people use it in day-to-day practice. And I think in terms of the hemisphere, the way that it improves our understanding of not just ventricular arterial coupling, but hemodynamics, is to break it down into simplistic levels. We have bits about contractility, we have other bits looking at afterload, we have sections that look at our preload, and that makes it simplistic for people to be able to use. I think the other interesting thing about the hemisphere is how you can customize the screens. So myself, I like lots of numbers, lots of trends. Other people will have a more simplistic view. When we take the monitor to the bedside for our nurse-led protocols, we may just have 2 or 3 parameters on there. So you can customize it to your need. I think that's the key for it.
Thanks, Simon, for the elaborate answer. Another question from Dr. Subramani. Is there any data demonstrating that HPI prevents excessive fluid administration compared to standard treatment in the perioperative setting?
Well, it's two answers to that. One is that if you only give fluid when there's an indication, in other words, that there's the HPI is elevated or stroke volume variation is elevated, or you haven't yet given any fluid, then you're not going to end up with a very fluid positive patient. The other thing is that, Simon, you've been doing some work recently about training and educating and using HPI, and there's nothing to suggest that there's excess fluid administered in any of the interventions that are protocol driven. Is that right?
That's correct. If you follow your basic goal-directed fluid therapy protocol, so giving fluid, I always say, Monty, your first litre is pretty much free. Up to 2 litres, you're in a relatively safe zone. After that, you have to think long and hard about it. We went through 3 different stages. So our baseline data collection, when people did what they want, we asked people to keep the MAP above 65. The second cohort didn't change the amount of hypotension. And the third cohort, we used HPI in a protocolized way. We didn't see an increase in the amount of fluid. We saw a decrease in the amount of vasopressors that we used and a slight increase in the amount of inotropes. So I won't say inotropes, Monty. We're not talking about starting adrenaline. We're talking about peripheral inotropic support from medicines such as ephedrine.
Awesome. There's also a comment from Dr. Anil Parikh and his team from Global Hospitals Mumbai that session, and there's a lot of things to learn. Another question from Dr. Chidananda on applications. I think we covered that, applications of HPI in the intensive care setting. There's one case, which has been shared by, one of our clinicians in Taiwan. So this is a case, and I believe, Simon, Monty, if you're able to see that screenshot. So it's a case of a 65-year-old, 165 centimeter, 85 kilogram patient, CAD with cabbage with Lima to LAD, a saphenous vein graft to obtuse marginal, a beating heart surgery without bypass. His pre-op 2D echo was 66%, as it shows in the photograph, and the HPI data was elevated to 94 after induction. Now, 15 minutes anesthesia with sevoflurane 1.5, rocuronium 10 milligram, fentanyl inotropic agent with dopamine, 4 mics per kilo per min. According to the secondary screen, now SVV was 9, DPDT was 547, had increased about 18% over 30 minutes, and EADINE was 0.7, which is decreased by 12%. What would you do in this situation? It's a long question, but more pertaining to specific.
We'll take this in 2 parts. So I would give a fluid bolus based on what we were saying earlier to see if the HPI comes down, and I would be ready with a little squeeze of phenylephrine. But there's also another possibility, I think, Simon, which I've never seen, but I've heard you talk about, which is the grey zone. With a MAP of 70, could this patient be in the grey zone?
So there is this concept of a grey zone. So when the machine learning process was being undertaken, hypotension was described or labelled as a MAP of less than 65, and not hypotensive was labelled as being greater than 75. So there's this area in between that we exclude from various parts of the analyses. So it is potentially, we see that sometimes that people can fall into this area between 65 and 75, and we can see high HPI, but with no impending hypotension. The other way to think about it is that there's no hypotension, but there is still instability. And I think that's the side we're coming down on now. I think the true false positives are a very small amount of data. For a large amount of people, what we have to remember is that HPI doesn't predict hypotension per se. It measures physiological instability that in the majority of people, when it reaches a certain threshold, will then cause hypotension. But you can still have a high HPI. You can have a MAP of 70, but that may be hypotensive for that individual. There's lots of instability there still, and that's how we're tending to look at it now.
And what we've demonstrated in the lab is that you can have variables that look like this. In other words, a stroke volume variation suggesting that you're not preload responsive, but we've taken 500 mils of blood off because that's the intravascular volume is deplete, and therefore you've sacrificed unstressed volume to put it into stressed volume. So you have central euvolemia, not preload responsive, but you're actually going to be HPI responsive. So that's why I would give the fluid bolus that we ready with the phenylephrine, and also just remain nervous that you might be in this grey zone that I've never seen, but we've heard about.
Well, I'd give Monty, I'd give fluid, a cautious dose of fluid, see what happened to HPI. If it came down with that, I think it's probably a preload issue. And if it didn't, then I'd start a low dose vasopressor and push that mean arterial pressure a little bit higher for that individual.
Awesome. So yeah, we are already above 2 minutes, but maybe let's take these last two questions and then we can conclude today's session. So one question is from Dr. Subhendu Sarkar asking about, can HPI give a proper prediction in position heart in an off-pump cabbage?
In off-pump cabbage? I have no
position
idea.
So once, if the surgeons pick the heart up, you won't be able to interpret it. Yeah. So if that's what the question relates to, in other words, if you're doing an off-pump cabbage and the heart's being manipulated, I don't know definitively, but I would be highly skeptical about the ability for HWI to reliably inform you if someone's picked the heart up. But great, if someone wants to do that project, crack on.
Awesome. All right, let's take the last question. Now, having data of HPI and PA catheter at the same time, do you think that the data obtained with the PA catheter is similar to HPI in making treatment decisions?
I think HPI gives you a huge amount more information than the PA catheter. You have the predictive ability of impending hypertension. You have the measure of instability through HPI. We know from work Monty and I have done that DPDT correlates very nicely with your left ventricular stroke work index. And you have the additional information of EA-dyne. So unless you're interested in right-sided pressures, so pulmonary artery hypertension, where absolutely PA catheter is still the go-to tool there. If you're purely looking at left-sided hemodynamics, I think HPI based off an arterial line gives you probably more information that's useful, and with the quicker refresh time as well.
Yeah, so circumstance dependent. As Simon said, if we're in the intensive care unit with severe acute lung injury, and we've got right ventricular dysfunction that's transitioning to failure, then the PA catheter is extremely useful. But in the operating room, the HPI has a huge amount to offer.
Brilliant. So I think we are just 5 minutes over, and I think that was a really great and engaging discussion. So with that, I would formally like to thank Simon and Monty for taking in time today for this great session. I think it was very intensive, very comprehensive, giving a lot of understanding of the applications of HPI in different scenarios in physiology. And I think this will really be helpful as we are growing HPI in the Asia Pacific region. So with that, I believe all of the attendees in here today would be more and more confident now with HPI, and you would go back and try to use it more in your patients, and thus helping manage intraoperative hypertension overall really better. So thanks a lot again, Monty and Simon. I from Edwards Life Sciences would really like to thank you. Again, thanks to all the attendees as well for being really engaged with all of the great questions in the session today. We really look forward, and we will continue with education sessions like this, hopefully with more experience from your end, hopefully more engaging clinical discussions around the applications of HPI. So any last and parting comments, Monty or Simon?
Goodbye.
Yeah, goodbye. I really enjoyed it. Some great questions, and look forward to seeing you all in person at some point.
Yeah, excellent engagement. Thank you.
Thank you so much, Monty. Thank you so much, Simon. Really appreciate it.
Good. Bye all.
So we will have, I will just put up a quick feedback questionnaire survey, for all of you. So if you all can, just take off your phones, and if you can provide your valuable feedback.